So after the jingle, I always forget about the jingle, which is, I think is important also. After this short coffee break, we continue with this second very intense day. And now it's time to go for the symposium that is done with collaboration with VIVA in Vitro Diagnostics. Thank you for your support to this symposium, but also for the whole meeting. And the title of the symposium is NLRP3 Inflammasome, okay? The missing link in sepsis survival. Why we are saying this title? Because we have discussed a lot these 2 days about subphenotyping, founding specific targets for therapy, but also this morning we have discussed about biomarkers for sepsis identification, sepsis prognostication, and of course biomarkers for enriching the studies and for improving patient selections. So during the next 50 minutes, we are going to discuss about which is the role of the inflammasome in all these aspects. So early identification, stratification, and subphenotyping for therapies. We have 2 speakers. The first speaker is Professor Evangelos Giamarellos from Greece. You know him very well. He still has a smile in his face. And this smile is translating that all the work he's doing in translating subphenotype to clinical practice maybe will produce positive results. So he's the optimal speaker for this session, from molecular mechanism to clinical phenotypes in sepsis. So Professor Giamarellos, the floor is yours. We're going to do the discussion at the end. So please stay with me when you finish, and then we will continue the discussion.
Well, thank you so much. Thank you for the good words. Thank you for inviting me, and also thank you for giving me one more topic for which there is no real conclusive remark. The idea is now to change this. So far, we were thinking how a phenotype may be linked to a biomarker or to a clinical response. So now let's see how the vice versa works. This is my conflict of interest disclosure for the presentation, and I would like to start with what we call a phenotype. So here is a phenotype. A life-threatening organ dysfunction caused by dysregulated host response to an infection, and I will insist on the fact that although traditionally we consider as infection the bacterial infections, this definition can very well apply for a viral infection. And here is the tool for the phenotyping. A patient may have, and the infection may have an impact on respiratory function, on coagulation, on liver function, cardiovascular, the level of the consciousness of the patient, and also the renal function. And all this together, they make a phenotype which has to do with the clinical characteristics of the patient. Originally, I don't believe that there is anybody in this room who is not aware, who has not read this wonderful article, which is coming from, is this a collaboration on 6 patient cohorts. The majority are coming from the States, from Pittsburgh. There is one cohort coming from Germany, and on top of them, there are cohorts having to do with trials of the past. One of them is even the PROWESS trial, which is a trial published in 2001 and which took place between 1998 until 2000. The idea behind that is that what counts is the clinical phenotypes of the patient, and of course there are a lot of question marks having to do with survival, just because the standard of care, for instance 20 years ago, was far different than the standard of care which we have nowadays. So these are the characteristics of the patients. You see that the enrollments, they differ greatly. Some of them, they use the sepsis 3 definitions. The majority of the cohorts, they use the sepsis 2 definitions. That means that some of the it was necessary in order to get enrolled to suffer from severe sepsis. But if you use the sepsis-3 definition, you may be enrolled just because you have an overall increase of your total score by 2 without having a single organ dysfunction which was needed in the definition of severe sepsis. And with this approach, which is actually a machine learning approach, a total of 24 different variables having to do with physical signs, with biochemical findings, whole blood cell counting, and coagulation are put together, and there is an attempt to cluster them into phenotypes. And as you may see, you can have 4 different phenotypes: alpha, beta, gamma, and delta. And it does not mean that there is one organ dysfunction which prevails in each phenotype. But the constellation and the clustering may lead the machine learning to cluster some patients to one phenotype over the others. What is really impressive is that you can see that for at least of these of the 2 phenotypes, and here we speak about the Seneca cohort, you have one phenotype which prevails. It's always the delta phenotype, and which is linked with the worst prognosis. The real question is, first of all, whether this can be replicated, and the second, if there is an association between the phenotype and the function of the patient. So we decided to replicate that, and we are thankful to Chris Seymour, who collaborated with my colleague Elena Karakike, and she gave her the formula. Let's put it that way. I'm not knowing anything about computational biology, so I apologize for all the bad terms that I will use in my talk. But the idea is that they used 3 cohorts of patients with sepsis, which you see on top. 4 cohorts of patients with bacterial sepsis, which you see on top, and another 2 cohorts of patients with viral sepsis by COVID-19. This is the clustering, so the 4 endotypes, by using the same tools. They can be, again, recognized, but what you see in the survival graph is by using a type of machine learning which is far more simplistic than the application of the 24 variables, because we can get exactly the same results by using 8 variables. What is important is that the delta phenotype kills more, and here is something which is a bit shocking. If the delta phenotype is to kill more, what we know is that from the very beginning, from day 0, you should have many more concentrations of inflammatory biomarkers in your bloodstream, but as you may see here, the blood levels of IL-6, CRP, and ferritin are exactly the same. Of course, this does not mean that the function is not different. We just have measurements of biomarkers telling that the biomarkers are the same. It could be the case, because there are no transcriptomics there, that the phenotype does not replicate here an endotype. Allow me now to, since I have to use the reverse order, that means to go from the molecular signs to the phenotype, to use an example of another trial. These are patients. I will not say what the patients have yet. They are critically ill, however. They meet the sepsis-3 definition, and they are randomized to get for 4 days a single intravenous infusion, either of placebo or clarithromycin, on top of standard of care. What is really impressive is that you see that on day 10, either patients who are grouped into the entire patient population, or the patients who experience a resolution of sepsis, they have an upregulation of the expression of HLA-DR by day 10. Which means that through treatment, at least using the lab, we see signs of restoration of the immune dysfunction of immunoparalysis. But for patients who escape from sepsis, the real danger is what happens if they get a new infection, a new sepsis. And here are the survival curves of sepsis recurrence. And you see that the likelihood of sepsis recurrence, if you escape from the original sepsis episode, is far less if you receive clarithromycin treatment than if you receive placebo treatment. So what we have in terms of increase of HLA-DR seems to get translated on the clinical grounds, and the question is, what are the characteristics of these patients? Are all patients together, or they belong to a specific phenotype? So these patients, of course, they meet the sepsis definition, but they have a real high SOFA score. That means that all of them, they are under ventilation at a PF less than 200, but they need for all other organs to get at least another 3 points from SOFA. So in other terms, our median SOFA score in this cohort was around 10. So what you see here, if you ask with the phenotypic tool of SOFA score, how this does replicates, it belongs only to the subgroup of patients with really high SOFA scores. Now I would like to move to the topic of the session. And there is a cell, and what you see there, I apologize if the cartoon is not really good, is nothing more than a phospholipid bilayer, a phospholipid bilayer of the tissue macrophages. What you see below the bilayer is the cytoplasm, which means that above the bilayer you are at the periplasmic space. But what you see inside the cytoplasm is a protein which has 3 main domains. One carboxylic domain which stands with the acronym LRR, leucine-rich repeats, and the amino acid domain which stands for pyrin. And from at least me coming from Greece, where the prevalence of Mediterranean fever is really high, and we believe that this is linked to mutations of the pyrin gene, this directly rings a bell. So all of a sudden, at the periplasmic space, you may have double-strand DNA, you may have ATP, you may have reactive oxygen species, even monosodium urate, and you may even have gram-positive bacteria, but not real infection by gram-negative, and not real infection sign, with the exception if you have a virus and you have there a single-strand RNA. The advantage of these molecules is that they can cross the phospholipid bilayer, there is no real need of a carrier, and they can bind to leucine-rich repeats. And all of a sudden, from the moment this happens, this monomer, which was apparently nothing for the cytoplasm, it polymerizes, and all pyrin domains, they come together, and they form an enzyme which may cleave procaspase 1 into caspase 1. What is really important with IL-1 is that IL-1 beta is never a mature cytokine. It should never become a mature cytokine, because if it is, all of a sudden we have a very high pyrogen reaction. So pro-IL-1 beta should be cleaved by caspase 1, but not more than 20% of the cleavage, or else you get fever. And then IL-1 beta is excreted by the cell. Now allow me to show you an example, and this mechanism that you see is the inflammasome, although I'm certain that if Charles Inarello was here, he would advocate that probably the inflammasome does not exist, and what cleaves the pro-IL-1 beta to IL-1 beta is nothing more than enzymes which are released by activated neutrophils. However, if you have agonists of NLRP3 inflammasome, which they activate the caspase activity, if they don't see pro-IL-1 beta inactive in the cytoplasm, nothing happens. Which means that somehow the cell needs to be primed. So in order to fill the cell with pro-IL-1 beta, someone has to activate pro-IL-1 beta. And the most common situation where this is taking place are patients who are obese, because TLR2, 1, and 4 is stimulated by free fatty acids, and then one innocent bystander, like for instance monosodium urate, may activate caspase and cleave pro-L1 beta to high concentrations of L1 beta and give rise to inflammation. Now, we know very well that when we have viral infections, patients who are at risk are those who are obese. We know very well that when we have such types of cytokine storm, we have patients suffering from diabetes. Nothing is by chance. And here is the isolation of visceral and subcutaneous fats from 44 obese patients, and you see that there is a linearity between the expression of caspase-1 and how much of fat you have in your visceral space. And IL-1, if it's overproduced, this leads and drives what is known as the macrophage activation syndrome. Some people, they love to call it cytokine storm. And the characteristic of this macrophage activation syndrome is the overproduction of ferritin by liver and the drop of the production of fibrinogen by liver, but also the activation of interferon gamma, which is coming from NK cells. Why? Because NK cells, they become immortal through the effect of IL-1 beta, and this interferon gamma mediates also hemophagocytosis at the level of the bone marrow. Here is the phenotype. This is a characteristic of patient with known immunosuppression, with high fever, with hepatomegaly or splenomegaly. Why? Because you need myeloid activation. With several cytopenias. The more the cytopenias, the more severe you get, because there is hemophagocytosis in the bone marrow. Ferritin, for the reason I explained earlier to you, increase of triglycerides, because there is a rapid turnover in the liver, decrease of fibrinogen, and also increase of serum alanine phosphatase. This is a score which is elaborated by the American College of Rheumatology. It's called the AHS score. If the total is more than 169, the sensitivity and specificity for the diagnosis is increased. This is how the score performs in patients with sepsis. These are Greek patients split into a cohort A and a cohort B. The A is the discovery, the B is the validation. In patients with macrophage activation syndrome, the score is significantly higher. As a matter of fact, the prevalence is around 4% in our hands. But look, another thing. It's completely different to have decreased platelets. It's completely different to suffer from disseminated intravascular coagulation. And it's completely different when this coagulopathy is coupled to liver dysfunction. If liver dysfunction and coagulopathy, they go together, you see that this prevails in patients with macrophage activation. And the characteristic is that in the survival model, even if a patient suffers from ARDS, AKI, or shock, this is an independent driver for mortality the first 10 days. Where we need to suspect the presence of this entity. In patients, as I already mentioned, who have both liver dysfunction and coagulopathy, and in patients with septic shock, because you see how much more frequent it is in septic shock than in the absence of shock. And this is a prospective validation. The patients with MALS, it's small numbers of patients, but yet the validation works. Aminotransaminases, they are increased. Bilirubin is increased. INR and APTT go down, and platelets go up, and platelets go down. I would like to conclude my talk with the fact that there is no universe phenotype. And it seems that when it comes to phenotyping and the mechanism, we need to consider all fields of medicine as one entity. Allow me now to share with you the trial which I believe is the most important and most thrilling from all the trials that have ever been done in the world. The acronym is CANTOS. This is a trial of survivors from a first episode of myocardial infarct, who they also have a CRP which is more than 2. And these patients, because this is a double-blind randomized trial, they receive for 5 entire years, every 4 months, either a single shot of placebo, or a monoclonal, which is called canakinumab, and which blocks IL-1 beta. The endpoint is the time to a secondary cardiovascular effect, and it's positive. And this corroborates the fact that if you are obese, if you have diabetes, if you have your endothelium suffering, you are primed for IL-1. At the specific time point, this cleaves through the inflammasome, a hyperproduction, and a second event can be prevented by treatment, but also it frames that although conventionally we narrowed down that those who do cytokine storm or who should do cytokine storm are the young, those who have a very potent immune reaction. It's obvious that this is not the case. We need patients who have comorbidities which prime the pro-IL-1 beta, and cardiovascular conditions is clear-cut such an entity. Thank you very much.
Thank you, Evangelos. We're going to have the discussion at the end. It's nice to conclude with our conclusions, as you said in your first statement. And also, it's why the phenotypes have Greek letters.
Well, this is something that I don't know.
Maybe you're responsible for that.
No, but we are.
Okay. So we continue to the second talk. So it's my pleasure to introduce you Professor Pablo Pelegrín. He's full professor in immunology in the University of Murcia and also in the Instituto Murciano de Investigación Biosanitaria. And he's going to explain us how we can measure functionally the activity of the inflammasome that you have alluded to. And then at the end, we will put everything together for the discussion. So please, the floor is yours.
Thank you, Ricard. Well, first of all, thanks for this kind invitation. I think very much appreciated to be here and be able to show our result on sepsis and the utility of the NLRP3 inflammasome. I would also like to thank Evangelos for this kind introduction on the inflammasome world. So this is my conflicts of interest, and I will give a more biochemical and structural view of the inflammasome, because the inflammasome is mainly in innate immune cells such as macrophages, monocytes, dendritic cells, neutrophils, and as you can see here, a few years ago we described the whole structure of the inactive NLRP3 inflammasome, which is on the left. And this structure is very tight and compact and leaves the pairing domain that Evangelos say in the middle of this structure. When it's activated, it conformational change. This cage open, and now this opening is very dangerous. And why is dangerous for the cell? Because as you see here in red, on the right structure, the pairing domain gets exposed to the extracellular, to the cytosol. And the pairing domain is dangerous because now it's able to attract an adapter protein, which is called ASC. And this ASC binds to this pairing domain in a prion-like oligomerization reaction. That means when a ASC binds to the NLRP3 complex, change conformation and allow another molecule of ASC to bind, and so on, with a prion-like oligomerization and forming big, very long filaments that we can see in the cells on the picture I show you here. This happens in many inflammasome, let's say, oligomers, and these filaments of ASC are very sticky. They all go all together in a big complex, oligomeric complex that we call ASC speck, because we see like a speck inside of the cell. And you can see the size of this speck is pretty much high. It could be up to 2 microns. And why this is important? Because as Evangelo introduced, this activates caspase-1. And caspase-1 is a very dangerous caspase because process different proteins. This is one of the proteins is processed, and this is important because make holes, pores on the plasma membrane. So the cell, they don't want to have holes on the plasma membrane, so it's going to die. And this die is pyroptosis. And pyroptosis, also coming from the Greek, is a highly inflammatory type of cell death. And why is it inflammatory type of cell death? Because caspase-1 can also process pro-IL-1 beta and pro-IL-18 to the mature form, which now leaks through these pores in the plasma membrane. So this makes the ideal cocktail for a highly inflammatory type of cell death, an inflammatory reaction. So now the inflammasome, we know that is involved in over 200 different diseases, chronic inflammatory diseases such as gout, cardiovascular disease, as Evangelos saw now, metabolic diseases, diabetes, degenerative diseases, neurodegenerative in Alzheimer, in aging. But what is more important for this audience is that they are key components for the fight against infections. So every time it gets infected, the NLRP3 inflammasome helps the immune system to mount an inflammatory response that is going to be important for the response against the pathogen. It could be viral, it could be bacterial, or it could be fungi. It has been found in different microorganisms that cause infection. So one will think, okay, septic patient has a cytokine storm, so the inflammasome will be very important in this cytokine storm. And it has been shown yesterday that very early on clinical trials with anakinra, which is the blocker of the IL-1 or anti-IL-6, anti-TNF, all these biologic in clinical trials of sepsis fail. And fail because they didn't stratify the patients. And now we are revisiting these clinical trials, and we are seeing that, in fact, the patients with a very high hyperinflammatory phenotype, they were benefited. But by that time, they didn't know, and this is why, because the septic patients is going to an immunoparalysis after this initial inflammatory storm. And this immunoparalysis is very important because now, as Evangelo highlighted, patients acquire secondary infections, which are compromising the life of these patients. So we need new trials, new drugs, and new trials with recombinant interferon gamma, recombinant MCSF are getting into treatment or novel treatment for this immunoparalysis septic patients. But we need a very early and robust patient stratification to run these trials. And therefore, we need reliable biomarkers for immunoparalysis. So how we do measure this immunoparalysis? We did 3 different cohorts. The 3rd cohort is ongoing, so any of you that want to be involved in this study, we will be more than happy to receive samples to validate in our method. So we started using abdominal surgery sepsis. And why we use abdominal surgery sepsis? Because they are quite critical patients, and the most important, they are developed in the hospital. So we can track the time for sepsis induction. So time in sepsis is very important, so we are able to collect samples within the first 24 hours of this sepsis initiation. And we can follow up 3-5 days of sepsis when the patient goes to hospital discharge, after recovery, where they are in their house. So the first thing we did, and that was published back in 2019, is just to measure what everybody knows, the inflammatory storm, the cytokine storm. We found high cytokines in the blood of these patients, high IL-6, high IL-8, HNGB1, acute phase protein, CRP, PCT, they are all elevated. And you are not surprising, and we were not surprising that any of them were kind of telling us which patients are immunoparalyzed or any of these biomarkers associated with the deaths that we see in these patients later on. So we decided to change the strategy. We are not going to look for a biomarker that is in the patient, because all of them are somehow elevated. We had a different approach, and we use something that probably you will understand very, very well. When you have a patient in your room, you ask to the patient, how do you feel? What are your symptoms? So the patient are going to respond you. So we decide to ask the immune cells, how do they feel? So we take fresh blood, we take the monocytes, and we ask the monocyte how they are. How you are going to cope to a secondary infection. So if now we activate the NLRP3 inflammasome, and that's the question, very easy question we ask to the cells, how you are going to respond. And what do we measure? We measure this oligomer, these big oligomers inside of the cells. I put it here with like a red dot inside of the cell, and also the release of IL-1 beta as a hallmark of inflammasome activation. And what we observe is that in septic patients, which are on the right, the gray and the blue, there are some septic patients that they do not activate the NLRP3 inflammasome, and there are another septic patients that they activate the inflammasome, like in normal cohort of patients, healthy patients or surgery patients that they do not develop sepsis. So at that point, we wanted to know that this, or I want to highlight that this is a 24-hour after sepsis initiation. And now if we track in a long term the survival of these patients, you can see here that the blue patients, the one that they don't respond, are already at 24 hours when they have very high inflammatory biomarkers in the blood. They accumulate over 80% of the mortality in this first cohort of patients. And the mortality starts after 10 days up to 1 month after this initial stratification. So we were able to stratify very early on the patient who has an immunoparalysis. The patient who are going to be reinfected, their immune system are not responding from day one. And if we now separate these two types of septic patients, the blue one, remember, are with immunoparalysis of the NLRP3 inflammasome. You can measure CRP, SOFA, or any different inflammatory cytokines in the blood at 24 hours. There are no differences. So they have a very high inflammatory response, all of them at systemic biomarker level. But their cells are not longer responding. We validated that in a second cohort. We refined the method, and you can see here very nice separation of the septic patients who do not respond, the septic patients who do respond in gray, and again, the one who has an immunoparalysis, they have an increased mortality. But not only mortality, also gravity. If we now will look, days in the intensive care units are higher. They are more days hospitalized. They need more days of mechanical ventilation, as you can see on the left graphs. So they have long-term markers of severity and gravity. We were able to put all together all the biomarkers we measured, and we did a ROC analysis for all of them. And in unbiased analysis, you can see there on the right that the NLRP3 activation ex vivo is a very nice biomarker with a high sensitivity and specificity to find these patients. And not SOFA, ferritin, STREM, PCT, CRP are not easily identifying these patients. But this is something we found by chance. So we feed all this data into a machine, and the machine gives us the representation of each single patient in a two-dimensional graph. So every dot is a patient. And now we see, okay, in all these dots, where are the immunocompromised patients that the NLRP3 inflammasome gives us? They close together, and they cluster differently from the septic patient with a functional NLRP3. So the activity of the inflammasome is very easily identified a subset of patients not previously identified, and can be very early to detect the immunoparalysis in the patients. So now in the third cohort, we are expanding from abdominal to respiratory and renal patients. We don't have enough patients of respiratory sepsis or renal sepsis, but the initial data seems that in other type of sepsis, you have the same phenotype. You have some patients with the NLRP3 inflammation to be decreased. And because we can follow now the activation over the days, you can see here in the dotted pink box that at day 1, at day 3, or day 5, the patient has this biomarker very, very low. So they don't activate the NLRP3 inflammasome. And for those patients who survive, those that are going back to home, you can see here after 4 months recovery, they also recover the activation of the NLRP3 inflammasome. So these patients, they don't have a genetic polymorphism or a genetic bias for a reduced activation of the inflammasome. So the inflammation can be recovered, and this immunoparalysis is transiently during the septic episodes. So that led us to think that this biomarker can be applied for clinical decision points. And one of the clinical decision points is when you discharge a patient from the hospital. And we decided to check patients who has a very low activation of the inflammasome at day 1, and once they are discharged from the hospital. And you can see that some of the patients, when they are discharged from the hospital, they already have a recovery of the activity of the inflammasome, but you have another that they are very, very low activity of the inflammasome. And what happened to that? They needed rehospitalization between a few days or few weeks with very strong and severe secondary infections. And some of them, the life was compromised in this second rehospitalization. So it's very important to know when the patient needs to be discharged and the immunocompetence of the patient is going to be optimal. So NLRP3 is like a very sensitive sensor to analyze the immunocompromised septic patients. So just to finish my talk, the take-home message I want to give you is that in critically ill septic patients, they can develop immunoparalysis even with high inflammatory biomarkers in the blood. They can have very high PCR, PCT, IL-6, whatever, but their immune cells are no longer responding to a second threat or second infection. The NLRP3 inflammasome activity is like a novel and very fast biomarker for functional immunoparalysis in critically ill patients. Remember, you can measure that at 24 hours or within the first 1, 2, 3 days, and you can see the long-term complication of the patients. The dysfunction of this inflammasome correlates with all these clinical complications in the ill septic patients, so they can be very early introduced to novel therapies to induce a burst of the immune system, such as interferon gamma or recombinant MCSF or other new therapies. And then NLRP3 inflammasome activity might help optimizing the therapies and help in critical decision-making points. For example, as I show you in hospital discharge, but I'm pretty sure you will have many other points and critical points where you want to measure the immunocompetence of the immune system. And this is not going to tell you any of the cytokines you will measure in the blood. That is going to only be telling to you by asking the immune cells, how do you feel now in that precise moment? So with that, I would like to finish acknowledging all the people working in my lab, especially Laura, Juan, and Elios, that are former people in my lab, but they were in charge of all these experiments, and of course all the funding agency and the hospital helping us to get samples to analyze. So thank you very much, and I will be happy to take questions. Thank you.
Thank you, Pablo. So now the topic is open for discussion. Anyone wants to start? Please. Professor Antonelli.
Very thankful for the beautiful presentation of you both. Really fascinating. Illustrating all the mechanisms that are behind. But as a poor clinician, I am confused. What I have to measure? The inflammasome, the interferon gamma, the IL-6, whatever. Can you give me just a suggestion, maybe for the future?
Well, this is a very interesting question, and this is why us as scientists are measuring many things, just to know what are the key elements that then we can translate into clinics. And what we have found is that, for example, the quantification of the activity of the inflammasome is a very nice sensor of the function of the immune cells. So if the immune cells is not working, and you can measure by different parameters, the patient is going to be more critical because you can have more chances to get secondary infections. And measuring inflammasome is a very easy and fast methodology, especially now that there are developing new assays to validate this inflammasome, like ELISA-like assays. So it's going to be very easy in the near future to measure NLRP3 inflammasome in the septic patients. The cost is not so expensive because, as I told you, it's an ELISA-based assay, so it's not going to be more expensive than, for example, IL-6 measurement. And that will tell you the function of the immune cells, not what the patient has in the blood, which is a little bit different.
Thank you.
Sure.
May I address a question?
Yeah.
I was thinking with your presentation, and that was really a beautiful presentation. Congratulations.
Thank you.
Could that just be the downregulation of NLRP3 an epiphenomenon of the overall immunoparalysis, or it is specific for IL-1. For instance, the same cells, if you stimulate them just with LPS, do they produce sufficient TNF? And what is the HLA-DR expression?
Yeah, they produce less TNF, less IL-6, but the best separation and segregation of the different immunocompromised patients is with NLRP3 inflammasome. It has higher sensitivity and specificity because, of course, we also measure the whole system, other cytokines. So that means it's a sensor for the global immunoparalysis, but the immunoparalysis is not just NLRP3. NLRP3 is a drop, but this drop is very specific and probably more than specific than
Is there any
TNF.
IVDR in this assay?
Sorry?
Do you have the labeling of in vitro diagnostics for this assay?
We are trying to get it.
For, I assume, immunoparalysis of sepsis?
Yes. But of course, it can also be applied, for example, for rheumatologists just to see the overexpression and overactivation of these pathways. So in sepsis, it's important to understand the immunoparalysis and the function of the immune system, because if you don't test the functionality, then it's difficult to talk about immunoparalysis, because you need to prove that the immune cells are not working anymore, or they are defective working.
Fantastic presentations. My question is, because it has been described and demonstrated that the patients with severe sepsis with an hyperinflammatory subphenotype are related with higher mortality if you compare with hypoinflammatory. So my question is, depression in these patients, as you demonstrate, what is the role in the short-term outcome? Because I understand that for long-term outcome is playing a key role, but at short-term, when the patient is admitted in the ICU, etc.
Well, what we found is that the patients who die with this hyperinflammatory reaction, and we think they are dying in that phase because they die very early on, they do have more activation of the NLRP3 inflammasome. So probably very early on, NLRP3 inflammasome, other toll-like receptor pathways are very highly induced to generate all this cytokine storm. But very quickly, the cells deactivate, and that's the sensor we can check. This deactivation. So the patient who don't deactivate the cells and has high inflammatory response, we can be treated by anti-interferon gamma, for example, antibodies, or canakinumab, anakinra. You have a big arsenal to block the inflammatory cytokines in that particular set of patients. But when you apply this drug, you need to be sure that the cells, the immune cells, are competent, that they are not failure, they are not working. Because if they are not working and you put more immunosuppressed, then you get a growth scenario.
Thanks for your presentation. This is Salvatore Cuduli from Rome. I have two questions, actually. The first one is, have you checked whether if you use another trigger different from endotoxin, then you can measure the same non-response or immune paralysis? And the second one is, have you identified specific drugs that may change the system, that may influence the system, apart from sepsis recovery?
Yes, these are two very interesting questions. The first one is, the answer is yes, but another triggers of the NLRP3 inflammasome takes longer time for incubation and activation, and we decided to go for a very short activation, which will reduce the time of potential diagnostic of this biomarker. But yes, you can have another toxins to be involved, even LPS alone. If you leave it for a long, it will activate NLRP3 in human monocytes. So this is completely feasible. We also have, and I didn't present because of the time, another inflammasomes that are not getting immunocompromised in the monocyte, like the parin inflammasome. So we have also internal controls where the system can be worked in these cells when you trigger by other pathway. And And the second question was about, you can...
Potential drugs that may
Yeah.
influence the immune response.
Yeah. We have here two things. Now there are very fancy NLRP3 inhibitors. They are getting into clinical trial phase 2, phase 2B, and some of them want to get into sepsis, and especially septic patients with renal failure. So it's very important to know that at least the inflammasome is not decreasing in these patients, and at least you have a normal or high activity of the NLRP3 inflammasome, as we were discussing before. So it's very critical to measure the activation of the inflammasome for this novel treatment, blocking specifically NLRP3, which are going to get into these trials. But as I say, also you can use recombinant cytokines to burst the immune system, or either if you have any hyperinflammatory phenotypes, as we were talking, you can also use blocking drugs, blocking antibodies for cytokines. Yeah. Thank you.
Thank you very much for all this story and potential implications for treatment, measuring or using this biomarker, or, well, let's say...
functional biomarker.
Functional biomarker. Okay, thanks for the correction. Okay, the same question that I asked to Evangelos, and this is for you, Evangelos, and for you. Are you sure that this is reproducible for any organ infection? This is very, because you say, oh, yes, sepsis, and you include 70% pneumonias, and then it's always the same. And then for each microorganism, it's hard to believe that there is a so common pattern for every infection and every microorganism. I think it's difficult, to me, it's hard to believe. It should be done, more studies should to be done in that sense, and to compare the different organ infections and the different microorganisms, because the trials can fail because that. Now you have the subphenotypes, okay? But you need more subphenotypes. Well, this is what I think.
Shall I?
Yeah, go on.
Oh, I guess I have that. I don't have the mic. So, to be honest, when I design a trial, there are two things I'm really afraid of, and for which I always try to introduce stratified randomization. The first is whether a patient has abdominal sepsis or not, because then by definition the need of source control can be a confounder, and a serious confounder for the interpretation of the data. And the other is, in case of lung infection, the type of lung infection, whether this is CAP/HAP/VAP. So I give you an indirect reply that my belief as a clinician is that I'm totally aligned with you, and I do not have lab data supporting this, but I believe that CAP is something completely different than VAP or HAP. And even if the biomarkers which we use so far, they demonstrate that the response is similar, this does not mean that we cover all biomarkers. There are thousands of biomarkers and thousands of proteins covered by proteomics or the omics technologies. So we should not do this type of generalizations. I strongly believe that you are 100% right, and pneumococcus is a completely different thing than Pseudomonas or Acinetobacter or Klebsiella.
Yeah, sorry, then why we try to simplify? Is it possible that the organisms respond in a so simplistic way? Just one mechanism for everything, for everybody, for every microorganism.
I do agree, but at a certain time point, you understand that if you want to do a trial, it's impossible to power a trial with so many limitations and so many sub-certifications.
Well, it was during COVID that we have that opportunity. We have all patients have the same infection and all the ICU is with the same patient. So in COVID, we could do that, but now we have mixed patients, and then, of course, we have to stratify the different studies. I want to take the last minutes because we learned a lot of things, but maybe I want to focus in a specific points that you both mentioned, and it was mentioned by Rosario and other speakers this morning, that maybe as intensivists we don't pay enough attention, which is the long-term outcomes and which is the consequence of sepsis and long-term for patients. So I think you are covering an unmet need in the acute phase because we have this phenotype of patients with high biomarkers of inflammation, but in fact they are immunosuppressed. And I think your tool can be very, very useful for identifying those patients during the ICU. But as intensivists, we should recover the patients at home with quality of life. I mean, at least with the same quality of life they have before. So identifying those patients that are discharged from the hospital in a frail immunological situation, this is very important. But I think nobody is doing that because we don't have responsible of that. As intensivists, we finish our work when the patient is discharged from the ICU, and then the continuity of care is not so good. What are your thoughts about that?
Well, I haven't come across a real big meta-analysis, but I had to meta-analyze data when I wanted to submit a grant for long, let's say, sepsis, if there is a syndrome of long sepsis. And I discovered there that from all what is published, it is impressive that from all those who are survivors by day 90, they stay survivors after 1 year far less than 50%. But in exactly the same way as long COVID is a type of research which is not really encouraged, I believe that the same applies for long sepsis as well.
Yeah. So you have a good tool for that. So I think this is also aligned, but we need to go together, clinicians and the new information you are providing to try to improve long-term outcomes in those patients.
Yes, because if you are discharging patients or the patients go home, and now we know that there are a lot of phenomena or trained immunity after infections that we are not analyzing at all. And all these phenomena are involved in these future clinical complications. But yes, I think completely agree that we should somehow continue the monitoring of these patients.
And the treatments you mentioned that are in phase 2A/B, are more to modulate hyperinflammation,
yes,
but not restoring the inflammasome, right?
Yes.
Okay, if there are no more questions, I think we have to close this session. There is one question, but should be very short because we are 3 minutes late.
Thank you. Congratulations for your presentations. I have just one question. It's frequent we have in our intensive care units patients who are admitted for sepsis, and the day before or the week before they are under treatment for cancer or autoimmune illnesses. How do you think that pre-treatment, that treatment they had before, it's a substrate, they are immuno-affected? How do you think that treatment could affect the immunoparalysis you are measuring?
Well, this is very, very, very interesting question, and of course it will affect. If you have an immunosuppressed or immunocompromised patient from the beginning, it's going to be much more difficult to cope with the initial sepsis episode. In fact, in the first day, yesterday morning, we have the wonderful talk about immunoparalysis or immunocompromised patients for sepsis development. So I think in our cohort, for example, we always wait for a long time for the potential chemotherapy or anti-inflammatory drugs to be expelled of the organism. So we have a strict exclusion criteria for this patient in our cohort. But of course, in the day-by-day clinics, you will have these patients, and that is a point that you have to know of your patient. So it could be affecting, of course. Glucocorticoids, for example, decrease dramatically the activation of the NLRP3 inflammasome in vivo. So we know that now. It's data that we are working on, and probably it's not published yet, but this is a very important issue. So it's important to measure in the septic patients how the immune system is. Even either if it is immunoparalyzed during the septic process or either if it comes already immunoparalyzed. So at the end of the day, probably it's a similar phenotype of patient.
Okay, thank you. We're closing here, and we start with the next session. Thank you.
Thank you.